Okay, so one kit you actually have to have sterile, and you want to get this onto your sterile area. You're going to use most of what's in here. If you don't have to, but I'll show you what you're going to do. You have a catheter in here. This is the catheter that's actually going to be the drain. It's going to stay in the patient for the next 24 to 48 hours, 72 hours, however long. You want to get that out, and you want it to be nice and straight. And then you have a wire that comes with it. You also have in here, I guess I'll do this, who was it? It was Rich Davis suggested. You take there's a piece that comes with it. It's a little white piece. It's like an introducer. You put it on the opposite end on this catheter. The catheter has dots, and it has a fenestrated end. That's the end that's going to go in the patient's back. This is the end that's going to be attached to our drain bag and our reservoir. So that's the end you stick this little white piece in.
I think he did it after the wire was in.
I did, but I don't know. Which do you think is easier?
I think it's awesome to put the wire in like you do, and then
Okay.
to put the catheter over the
do it
wire.
that way. All right. So I've got this catheter. I'm going to lay it straight. That's really important. Then you take this wire, and you've got to put this thing all the way through so that it is no longer a flimsy catheter.
Starting from the non-fenestrated end.
Thank you, Brian. You might want to mention things I'm forgetting.
I'm going to just say again, because I might have cut it off on the other video, that
All right.
Ryan's got an epidural kit, a brawn or an arrow, whatever, for some of the supplies that are in there, including a cap that you'll use on the lure lock, the chloroprep, the tegaderm. Mm-hmm.
So that is now wired.
Maybe the local anesthetic.
So you can leave that. So you have your needle. You do want to make sure you know the markings on it. This is 10 centimeters. Fenestrations, we think, stop at about 5, it looks like. You want to leave about 5 centimeters in the space anyway.
Yeah, say at least to the fenestration, because otherwise you're going to be getting blood from the epidural space in there. So at least 5. You may want to leave it, 8 or something.
And it's a really flimsy catheter. Once you pull that wire out, it's not going to harm their neuronal structures.
Cautoquinone.
Yeah. And then it's got every centimeter's got a marking, so you will know, and the needle itself has the same markings on it as an epidural needle.
Yeah.
So as you go in, you know when you get your CSF back, you know how far to the space. That way you can calculate how much you want to leave in there.
I believe that's 14 gauge.
It is a
no
14
wings
gauge
on
needle.
it though.
I believe there's 9 centimeters from here, from tip to here.
Okay.
It's about 9 centimeters, I believe. Anyway, and so there is a piece on here you can attach if you like that wing.
The wings.
You can
Oh yeah.
use that if you're more comfortable with that, or you don't have to. You can just do it without. So once you have this laid out, you've prepped your patient. That's all ready. You have you've already localized. You're going to then introduce this into their back, and you do it just like any other spinal. And then once you get CSF back, or once you feel that resistance or loss of resistance, you want to pull your needle, your introducer out slightly. If you pull it out just slightly, you'll start to see some fluid come out. You'll know you're positive. You can push it back in for a second. Because what you're going to want to do is, since your catheter is ready, you have to be quick about this. You don't want to lose too much CSF. So the best way to do it is to have a good grip here. As you're pulling the stylet out, you want to then get ready to start introducing your catheter into the same orifice that you're pulling this stylet out, which is kind of hard for me to do with. There we go, if you want to hold that. So I'm pulling this out, and I'm getting ready, and got it here. And there comes a point right there. It's a smaller part of the stylet. It allows you to actually introduce into it. And then that comes out, and then you advance this catheter into the patient. And about this point, you should start to block off all the CSF, so you're not really losing any at this point. And then, depending on what this marking is here, where you're at the skin, you have your 10, which was already inside here. 10, I believe, was right there. There's 10. So this is going to be 20, and this is going to be 30. And so you go until you figure you're in deep enough, according to whatever the calculation is there. And at this point, you want to then, you leave the wire in, you just pull this needle out, because it can be difficult.
Sorry.
That's all right. It can be difficult if you don't, so you leave the wire in place until the last minute, then you're pulling this out. And then once you get that needle out, I think they were recommending, one option is you can now take this piece that is going to be attached to the, you could attach that now if you wanted.
Thread it over that wire.
Thread it over
that's
the
there.
wire if you wanted to. The
Neat
point
little
is,
trick.
this just at some point needs to get on there.
Yeah, it's a cool
I
trick.
don't know why. It's so difficult to get on because
I
it
know.
wasn't when I first opened the kit. But
Maybe
now,
we beat it up a little
I
bit.
think we beat it up. Anyway, so then you pull your wire out, and the easiest way is to have this thing nice and straight as possible.
Hmm.
Oh, maybe you're
Maybe have
you're
one at the
gripping it
skin.
too tight.
I'm sorry.
That's
Maybe,
all right. That's what
maybe.
I think it's.
Yeah, it's very so flexible.
There
man,
it is.
You know.
Yeah. So you pull that out, and now it's really going to get flimsy like a noodle. And then you can get rid of your wire. You're done with that. You want to make sure this piece has been attached. And I don't know why I can't get in there, but it's kind of important.
Yeah, it is.
Why can't I get this in there? Was it oh, it's the wrong piece, that's why. This is the piece. I lied to you guys. It's the clear piece. Do you guys see the difference? This was the one that actually came with the wire.
Oh, that's cool.
Alright, just so you know, it's the clear piece that you want. That's the one that actually fits in there.
How about that?
And then, if you too deep, you already know your calculation, it looks too deep, you can then start to back this out to where you want it to be placed for the duration of the catheter. And that's it.
All right. So how do we hook it up to the
So-
wall after we've secured it? and
Oh, then you
everything?
take your epidural cap that goes to your catheter on
Yeah.
your epidural. It's the yellow one. I don't know what color it is on the arrow.
Blue.
And blue, you just screw that on tight so that no CSF, and then you can tape it up, mastisol, whatever you like to do. And then there's that sterile drape also, or the sterile tegaderm from the kit. You can also use that and cover it up. That's the other reason, part of the reason why you use that.
Yeah.
So then, when you're ready to set this thing up, you've got that all done. You have your second bag of tools, of equipment that you need. And this thing comes pretty much all together except for the reservoir bag. That's the only thing you really have to attach. And it's a simple attachment, just screws onto the bottom of the cylinder. And you'll know the bottom of it because one side says up.
Mhm.
So, and it says do not tilt. And this cylinder then, where did
Is there one more piece?
attached? There it is. Alright. So this is actually all attached. Maybe I took it
Sure.
off.
No, that might have been my fault.
So this is the piece right here. This is the end. This is the end that will then attach to your catheter. Right there, it screws on nice and tight. Now it's a closed system and it's sterile. I usually tend to close this off until I'm ready to make sure, so I know that the patient's not going to be moving and they're going to be in a supine position, and then I open it up. Because on transport, it worries me thinking that if this is open and all of a sudden I lower this, their pressure could push too much CSF through, and I don't want to do that. So I just close it off to the patient in transport just to make myself feel better. So that's attached to the patient. Now this piece is the reservoir, and that really doesn't matter much other than being in a closed unit, and it's just going to kind of dangle. There is a tape measure
Good.
that's provided in this kit. And this tape measure will go onto an IV pole like this. It has a 0 mark, and then it has two sides to it. Blue represents millimeters in mercury, and the black represents centimeters of water. We will use the blue side when we're measuring, when we're setting up the lumbar drain.
Millimeters of mercury.
Yep, millimeters of mercury. And the 0 needs to be at the patient's auditory meatus. External auditory meatus.
Just like
so
that.
if they're supine, this is where it would be. Okay? That's where you need to mark your 0. Then you take your tape, you tape it onto an IV pole so that this 0 stays at their auditory meatus. The reason why that's important is because then you're going to take this cylinder and it has Velcro straps to it. These Velcro straps wrap around the same IV pole where this tape is on, and it has a pressure level at the very top of it. You can see that. So that pressure level then you want to attach to the same IV pole, and you want to place it anywhere between 10 and 12 millimeters of mercury. So if this is my IV pole, I'm going to want that pressure line to be right there.
Yep, 12.
And it'll Velcro right around the pole so that you don't have to hold it or do anything else. It'll keep it nice and still for you. If the patient's bed moves up and down, though, you have to be sure that this moves up and down according to where their auditory meatus is. And
Awesome.
that is it.
That's pretty much it. And
What else?
so that reservoir bag, does it fill up continuously?
So the reservoir bag, what you can do is that's a good thing. You turn this stopcock so it's off, so that you can measure how many cc's you have drained during the case. Very important. Once you've calculated, what I typically do is I leave it closed the whole case, so I know what I've drained, and then when I take it to the ICU is when I basically empty it into the reservoir, so then they can start measuring from their point, and we make a note of how much we did during the case and maybe in the recovery room as well.
I forget when they're ICU how often we have them check it. I don't know. To check the CSF fluid drainage, but
Well, they
I don't
need
know.
to check it almost hourly because we don't want them draining more than 15 mLs an hour.
Okay.
Because that can be a complication for the patient.
Okay.
At least they can be prone for complication if they're draining more than 15 an hour.
Yeah.
I try to do it 10 myself, but that's just because I'm scared.
And we'll attach to the same email a little paper that
Yes.
Alicia has about how to manage them. So
Yeah.
very good. Thank you, bro. You're the
That's
bomb.
it. Did I forget anything?
Not really. I mentioned how we had the epidural kit. We have a kit that looks like, it's kind of nondescript to be honest with you, but there it is. There's the kit that has the actual drain in there, pretty white box. And then of course we have the towels. 3 of those and some gloves and you're ready to go. All right. Peace. Call that guy if you have any questions.